This video is part one in our four-part series on why mid-back pain between the shoulder blades usually isn't a rhomboid problem. In the video, I cover the following: the mistake providers make by only treating where the pain is, causes, locations, and symptoms of an accessory nerve entrapment, and detailed testing, palpation, and functional-based treatment demonstrations to fix the nerve entrapment. For those of you who don't know me, my name is Dr. Matt Maggio, and I am a non-surgical expert in chronic pain treatment, specifically for conditions affecting the neck, upper back, shoulder, and arm. My focus is on finding and fixing nerves that become stuck to muscles with a glue-like substance called adhesion, also known as scar tissue, and then reducing inflammation from chronic pain naturally without the use of medications or injections. This leads to a big increase in flexibility, functioning, and long-lasting pain relief. I'm also the creator of the PEAK method, where we teach overworked massage therapists a new injury treatment system that allows them to cut their treatment times by at least 50% so they can avoid that dreaded burnout and help more people get out of pain. All right, so this is going to be a four-part series on why pain, shown here, usually isn't a rhomboid problem. This is going to be an accessory nerve entrapment video, so let's get right into it. So some common mistakes providers make, and I made them a lot myself over the years, is only treating where the pain is. A lot of times we do this, you're busy in practice in your clinic, client comes in and you have them fill out some basic intake form and they circle where it hurts, and then you jump right into the treatment, not really knowing what's actually going on there. Then you got these people, I can't stand them, they're the worst. They're called intuitive healers and they're nonsense and they're full of garbage, and they say they can just let the tissue talk to them and they know exactly where to go and what to do and just communicate, and they're tuned into the aura. Yeah, whatever. If you want to do that stuff, that's fine, but you're not fixing anything, and you make everyone else look like a bunch of whack jobs because you are. Next is not slowing down by asking enough questions. In my trainings and what I teach is we teach a 12-question history approach for every single client before we even think about laying our hands on them or using our hands and getting that data as well. Very in depth, helps us really get to the root cause of what's going on. Because I always say, if you don't know what the problem is in the first place, you sure as hell can't fix it. And the last mistake is not doing any testing to make sure the issue is actually there. We rely too much on symptoms like, oh, it hurts in the rhomboid area in the mid-back. Got to be the rhomboid. Let's treat the rhomboid. But there's a lot of structures, a lot of things that live there, and a lot of things that actually can get caught. And your job really, I really want to teach people more to be what I call less of a technician and more of a clinician, like slowing down, collecting data, figuring it out, having tests so you know right where to go. I think a lot of treatments really stuck in what I call shotgun approaches. Try a bunch of stuff and you're like, yeah, I don't know what's going to happen. I'm going to try something new. I really try to teach more of like a sniper approach, like lining it up, getting it, and getting the right type of treatment every time. That's what actually gets durability and long-lasting pain relief. So spinal accessory nerve, it is actually the most common entrapment in the upper body in every human because of modern society and what we do. So accessory nerve is kind of interesting. It's actually one of the cranial nerves that comes out from the brainstem, and it's strictly motor to the trap and the SCM. It's one of the few cranial nerves that actually leaves like the central nervous system and goes out. So it's very interesting. So where does it get caught? Right in this area, usually from like the C7 all the way across to the inferior angle of the shoulder blade. I'll get caught a little bit higher up in the levator as it goes down in there, but very common for that to get entrapped and caught. Symptoms of an entrapment: when a nerve is entrapped, it's usually like starts off with a little bit of numbness, aching, burning, tension. People just feel kind of uncomfortable. They're always moving around to try to take some pressure off of that area. Why is fixing the nerve first so important? Over the years, I always thought it was just the muscle and the fascia and the ligaments. But the thing is, when a nerve is entrapped, it kind of throws off everything. It throws off the biomechanics. The body will really do whatever it can do to not have the nervous system overloaded. And if you don't treat the entrapment first and you treat around it, that problem's going to come back. I think the neuromuscular people have it wrong. They think that it is a problem with the nervous system, but they think it's coming from the brain. I think it's coming from out in the periphery where it's getting stuck, and it's that nerve entrapment that's causing it. So next is just going to be some detailed testing, palpation, and functional-based treatments, demonstrations to fix the nerve entrapment, because we got to find it, then we got to fix it. So the first video I want to include is me going through a full functional test of what I call the lower cervical, upper thoracic area, going through all that. I'm going to link that up right now.
So this is what we're going to call lower cervical spine thoracic flexion test, because basically we're going to go from about C6, C7 all the way down to T4. And this area is so dysfunctional in pretty much every human being. So the first thing I want to do is I always want to assess this in a chair. That really helps things stay nice and relaxed, and you want a chair with a nice solid back. The first thing is the client position is going to be very important. You're going to have them put their legs together, feet together, kind of like what we've done in other tests. And the first part of that motion, what you're going to do is have the client just drop their head straight down, but you want to make sure that their back stays in contact with the table. So we do that first one. Now we do that again, drop the head down, and this is where you go in and ask the important questions. Where do you feel the pain? What does that pain feel like? And how intense is that pain? So now we have that data. Now we'll get our pencil out again, and this is going to really help. So come real close on this one. So this one is really key to get a picture of. And a lot of people, and you'll see this specifically in women, they get this outpouching, or what's called a granny hump. And this granny hump is starting to happen because there's a lot of dysfunction in here. So we're going to take the pencil and get it lined up just like this. So this is C7 right where it goes. And you're going to put the pencil in here, and you're going to kind of go down and look for areas where it's really flat. And what we're seeing now is it's very flat all the way through here. We should see that only that 3 is touching, but you see in here, it's going from the 2 all the way down to the 5. So there's a lot of dysfunction in there. And what it does is it puts more pressure up in this region. Now this test can be a little, this test can actually create a lot of symptoms, so you don't want the client to hold into that too long. So once you've established the area where that dysfunction is, where that flatness is, that's when you'll go into your palpation. So you'll have the client drop down just like that, and what I'm going to be doing is holding their head here. This is very important, and I'm going to be pushing back on the chair. That'll help everything settle down and not feel so inflamed. So I've located that area where that problem is. Now what I'm going to do is get in here and palpate right on that ligament, and this is called the interspinous ligament. I'm going to work my way down, and I'm seeing that there's a lot of tension in there. When there's scar tissue, it just doesn't want to move. Then based off of that, I'll start to palpate around the erector group in there as well. And usually when you find some flatness there, you're going to find some dysfunction in this supraspinous ligament, which in turn is going to put more pressure down on these erector groups as well. Now the key here is really holding this in place and helping support the head. If you let the client just kind of hang out for that in a long position, it's going to flare up a lot of things. It could actually put some pressure on the joint and the disc and the neck. So the key is the motion. You just drop it down and you support it and you put it back just like this. And this one is really key, where you can get in there and put the pencil down, and in that short moment when you're putting the pencil down, you can hold it in there, and that's when you're going to get out your cell phone or your camera. I would recommend a cell phone, and you're going to take that picture from the side. And when you take that picture from the side, they're going to be able to see that pronounced hump, and they're going to see all that flatness in there, because the picture really gives a lot of data and gives an idea of what's going on.
So once again, you can see I'm slow, I'm deliberate, and I'm really trying to collect all my data. I don't want to be in a rush to do a bunch of treatment. I want to do the right treatment. Next thing I'm going to do is include 2 parts in here. One is going to be palpation of that area and really finding where that accessory nerve can get entrapped. Then I'm also going to demonstrate some functional based treatment to actually break that down. So I'm going to link that up right now.
So once I find it, I don't really leave my thumb off of it, because then I know I'm there and I won't leave it off of there. Now the key is going to be the setup. So you're going to tell the client how you want them to move. She's going to start back in some extension. And then I'm going to have you drop your head down nice and slow, just like that. And they're going to drop it towards their chest. So what I'm going to do now is I'm going to bring it back in extension. Now the setup here is really key. So I have my thumb here just like that. And what I do is I come in at a 90-degree angle. So I'm facing opposite to the wall. Some people go like this, that's not good. Or they're here, and all you're going to do is bleed out some force in there. So what I'm gonna do here is the scar tissue's here. I'm gonna be just above that. And the first thing I'm gonna do, I'm gonna come in at 90, and you see how my elbow gets nice and high. This is gonna allow me to accommodate for that 45-degree angle in there. Next thing I'm gonna do is I'm gonna take my other hand, and specifically like the piezoform and the web here, and that's gonna go in and basically cover up that thumb and protect that. So I'm here, and I'm here, and I'm in a really good position, and see how everything's lined up, and this kind of gets that line of drive as we go in there. In order, first we got to get depth on it, and my depth is going to be just a very slight lean with my hips in there. And if you're pushing too far, the client will move too much. You don't want that. It should just be enough where you're going in very gentle like that. Then the next thing I'm going to do is I'm going to drop my elbow just a little bit, just like that, and I'm going to kind of pull it in towards my body a bit, and then I'm going to drop a little bit more in a squat. And that's really loaded up. Now the client's ready for me to go through the motion, and go ahead. And I'm just feeling it pull, 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 pull. And as I'm getting more tension, I'm kind of leaning away with my body and down and pulling with that elbow. All of my force is coming through my thumb, but I'm keeping my depth with this other hand.
So I demonstrated the treatment, the palpation, but there are some errors that people have, especially when they treat this area. First is this, their depth and tension is off. You know, they encounter the accessory nerve entrapment. A lot of times they think it's a trigger point. It's not a trigger point, it's a nerve entrapment. That's totally different, a totally different thing. But the thing about that area in that thoracic spine is you have the rib. So it almost has like a 45-degree curve. And I talked about that in the treatment video and getting the elbow just right. What I end to find a lot is when people do encounter it, they actually go straight into it and they just create a lot of depth, but not enough tension. You got to get depth and tension to actually break that down. They don't account for the angles, as I said. They're just really kind of beating the hell out of the area, and they go in there and stimulate it. Temporarily feels better, but didn't remove the entrapment, so that problem's still there when they come back next time. Next is just not letting the tissue slide. I always say the nerves are like the Goldilocks of the musculoskeletal system. They want just the right amount of depth, just the right amount of tension, and they don't want to get beat up too much. And then lastly is just treating too aggressively. Usually when I encounter pretty chronic nerve entrapment, I'm usually only treating it for like anywhere from like 3 to 4 passes, and I'm going really slow, really deliberate. I'm not trying to just beat the living hell out of the area, because if you do too much work on it, everything's just going to get inflamed. It will temporarily feel better, but it's not going to actually fix the problem, and it's just going to anger it longer, and the client's going to be right back to where they started. That's all I got in the video. I appreciate you watching. Any insights you might have gotten from it, you know, drop it in the comment section below. I try my best to answer anything or share some resources or videos that can help you, you know, improve your outcomes, your practice, help more people that are in chronic pain. You can also do me a solid and share this with other providers that you know might help. And lastly, go download our free training modules where I really go into figuring out exactly a main cause of chronic neck pain, how to assess it, how to palpate it, how to treat it, and manage it as well, and really get you on the path from not just providing a service, but providing a solution and helping those in chronic pain, learning how to do it better, then faster, so that you can be so good in your area that nobody can ignore you. I appreciate you watching the video, and I'll catch you on the next one. Bye.